Good evening, and thank you very much for joining us this evening for this webinar on the topic Optimizing Vascular Access and Patient Safety. Vascular interventions are an inevitable part of critical care. From simple IVs to hemodialysis and stents, there are different kinds of vascular access devices used in critical patient care. It is therefore necessary to have a conversation around the safety of such vascular interventions and how it can be ensured. We welcome you to this webinar organized by the Times of India in association with the Critical Care Division of Biological E Limited, one of the leading producers of anticoagulants in India. Let me introduce our panel for this evening. We are joined by Dr. Srichandran L., the Consultant Interventional Cardiologist from the he's a Senior Consultant Interventional Cardiologist at the Department of Cardiology at MGM Healthcare Private Limited. We are also being joined by Dr. Madan Mohan B. He's a Senior Consultant Interventional Cardiologist at the MGM Healthcare, and he's also the Clinical Lead at the Department of Cardiology. We're also joined by Dr. M. Swamikannu. He's a Senior Consultant and Clinical Lead at the Department of Internal Medicine at MGM Healthcare Private Limited. We also have with us Dr. Shivraj P. He's a Senior Consultant in the Department of Internal Medicine at MGM Healthcare Private Limited in Chennai. Thank you very much for joining us this evening, sir. So diving right into the webinar, I have my first question for Dr. Srichandran right now. As an interventional cardiologist, what are some of the common types of vascular access procedures that you perform on patients, sir?
Good evening. As an interventional cardiologist, we would be performing both diagnostic and therapeutic procedures in the cath lab. Few of the diagnostic procedures would include a coronary angiogram, which is a diagnostic test to study if the patient has any blocks in his blood vessels of the heart. That is called a coronary angiogram. Simultaneously, we'll also be doing angiogram involving the peripheral arterial system. That is, we call a peripheral angiogram. Then there is also would be doing therapeutic procedures like an angioplasty, simple and complex, and also multiple complex procedures involving structural heart disease, and also peripheral angioplasties, and also subsequently also temporary pacemaker implantations and permanent pacemaker implantation. So the scope is big actually. So as an interventional cardiologist, we are involved in both diagnostic and therapeutic procedures.
Thank you for clarifying that, Dr. Srichandran. Let me go over to you, Dr. Madan Mohan. My question for you is, as vascular access devices, or VADs as they are called, are being used almost daily in all inpatient settings, what are the major challenges for healthcare professionals with regard to patient safety?
Good evening, everybody. So whenever we start doing this puncture, when we enter the artery, we make a puncture to the blood vessel. So that site is very important for anybody. The site should be free from any rupture or the blood clot formation in and around the blood vessel site when we are puncturing the blood vessel. So we should take care when we puncture the blood vessel. We take puncture at different sites of the body, like one in the leg area and another in the hand area and near the chest for pacemaker. So whenever we do puncture for all the three sites, we have to be very careful because that is very important for anybody. Like a blood loss means then a patient will collapse on table. And if the blood gets collected on the site that we call it as hematoma, that becomes a later on very critical issue. So we have to be very careful when we puncture the blood vessels of the body. So in that we take one angle is X-ray, that is fluoroscopy, we call it as fluoroscopy in the cath lab. So we mark the site and correctly we take the puncture on the blood vessel. We have the landmark already calculated with the fluoroscopy. So it will be easy for us to enter the site of the blood vessel. Why we take the fluoro is sometimes we may puncture above the artery. So in that case, when we in the leg, when we puncture above the artery, like it may bleed inside the abdomen, then cause the whole abdomen with the blood inside the abdomen. So that is the main reason we should be very careful when we are puncturing. And we create a puncture below the area of site, then the whole leg will be getting collected with blood And there is one system called like an aneurysm, where the artery gets bulged. That's called aneurysm. Sometimes the artery and vein gets interconnected. We call it as arteriovenous fistula. So these are all nuisance in the future when we don't puncture properly at the exact site. So we have to be meticulous and correctly position ourselves to puncture with the fluoroscopy guided. And other times we take the ultrasound. So the ultrasound gives us the correct guidance to puncture. So whether we are on the above the artery. So ultrasound neatly, precisely say that you are above the artery. So ultrasound will be very useful. Nowadays, we started using ultrasound guided puncture. So even when near the chest area, when we are puncturing, there is a lung behind it. So when you puncture the lung, then the whole lung will explore with air outside. So we call it as pneumothorax. So we have to be very careful on puncturing the vessel near the lung area. And when we put some catheters inside the jugular vein for central venous pressure to monitor the heart pressure, there also we have to be very careful when we puncture this area because it has more blood vessels and other structures nearby. So we have to take with ultrasound guided, particularly in this area, to puncture the site. So these are all and one more gadget we have is micropuncture. So which is very small size, which when we put inside like a small needle inside the artery. So even when we puncture at the neighboring structure, it may not cause any major issue when we are puncturing. So micropuncture catheter needle is a precise gadget to prevent bleeding or hematoma in and near the structure around the blood vessel. So these are all the gadgets we normally take to prevent blood and puncture site blood clot around it.
Right. Thank you so much for explaining that in so much detail, Dr. Madan Mohan. Let me go over to you, Dr. Swamikannu. What are the general patient safety measures being followed as part of the protocol?
One of the commonest procedures that is performed on the patients who are admitted in the hospital or as patients is the peripheral venous cannulation. So from the patient point of view, there are several things which is important. You have to make sure before you do the procedure. The first thing is you have to identify the patient, whether you are doing it on the right patient. So you check the name of the patient, age of the patient, hospital number. Then you also, because sometimes patient may be conscious, sometimes patient may not be conscious. So you may not be able to tell you the name and the age. So you have to check the band. Usually there is a band tied to the patient when they are admitted. So you can cross-check with the thing. Then you select your site of cannulation. For that, you need a very good knowledge of anatomical knowledge of the veins and the arteries. Then you have to take the consent from the patient, whether you are doing it for diagnostic purpose or therapeutic purpose. What is the purpose of doing cannulation? The patient should understand it's a blind procedure. You may not be able to get it at first puncture because it is a blind procedure. Sometimes you may have to try 1 or 2 times, maybe sometimes 3 times. That they have to clearly understand it is a blind procedure, so that not every time you may not hit the vein. Once you decided you get the consent from the patient, you select the site in such a way that it will not interfere with day-to-day activities. And you tell them why you are selecting that particular site for putting a venous cannula into that area. From the patient point of view, you have to minimize the pain when you are doing a peripheral cannulation because it is, whatever said and done, it is a painful procedure. So once you do the cannulation, you have to make sure that you are following all the safety precautions. Cleanliness, then doing the procedure at the aseptic measures with the aseptic so that they don't get infections in the coming days. Then once you put the cannula, you have to decide whether you are doing it for diagnostic or therapeutic purpose. That you have to inform the patient in advance. Suppose you are just drawing the blood for some testing, it's called diagnosis. Suppose you are going to administer some drugs or the fluids, that is called therapeutic intervention. So the other thing that you have to inform the patient is the peripheral venous cannulation cannot be kept it for a long time. The number of days that should be limited is 3 to 4 days. According to the international standards, you cannot keep it for more than 4 days. The why you should not keep it more than 4 days is because it is a needle topped with a plastic cannula. This plastic material can cause irritation to the blood vessels and inflammation. It can also sometimes cause the infections, what is called bloodstream related infections. So it can also cause inflammation of the blood vessels, what is called as phlebitis, thrombophlebitis. Sometimes when you cannulate, it can start bleeding if the patient has a bleeding tendency. So it is important before putting the cannula to take all the precautions, and once you put the cannula inside, then make sure you properly secure the cannula, because during sleeping time it may come off if you don't fix it properly. So fixing the cannula is also it's a responsibility of the person who does it. After every day it has to be monitored and flushed for you have to look for infections in and around the vein where you have cannula. So all these safety measures you have to take whenever you decide to do a peripheral venous cannula.
Right. Thank you for that, Dr. Swamikannu. Coming to you, Dr. Shivraj, just taking off from the other doctor's point, what are the common risks involved in vascular access? What could be the possible fallouts if it's not done properly?
Let me just clear out one thing. So when we say vascular access, it means what vessel are we accessing? Okay, whether we are accessing the artery or the vein. That's number one. Number two, whether the artery or the vein, whether it's a peripheral or a central. When I say peripheral, it's a smaller structure. When I say a central, it's a bigger structure. The common structures, like as Dr. Swamikannu sir was telling, is a peripheral venous cannulation, which is commonly done in the ward for administration of drugs and so on, and or for drawing blood as well. Secondly, for the arteries, usually the posterior tibial or the radial arteries are involved for the cardiac procedure. When we say about the central venous cannulations, the central venous catheterizations, okay, it depends on which site are you doing it, okay, whether it's like a short term, mid term, or a long term, okay. So the common sites which are used for the central cannulations, for central venous catheterizations, are the jugular in the neck, and in the chest we have the subclavian, and in the thigh we have the femoral. Which site to use, it depends actually. Each site has got its own advantages and disadvantages. So coming to your question about the fallouts, okay. So when you use a peripheral venous access, make sure, as Dr. Swamikannu was telling, make sure the area is clean, and because there's more chance of phlebitis. That's an inflammation of the vessel, which is called a thrombophlebitis, which we usually see. When doing a central venous access, the common risk is bleeding. That is the most common risk, because you do the central access for very sick patients, and most of the time they have a condition called coagulopathy. So what do I mean by coagulopathy is an altered PT-INR, okay, and an APTT. This is a test we usually do. So when these values are really altered, there's an increased chance of bleeding, okay. And there's a simple test called platelets, which we check before the cannulations are done. If the platelet count is less than 20,000, and if the PT-INR is more than 3, there's increased chance of bleeding, okay. What do you do then? So the patient needs to be cannulated as well. So what do you do then? So you transfuse some blood products. The common blood products, if the platelets are less than 20,000, you transfuse platelets. If the PT-INR is more than 3, okay, so you give them fresh frozen plasmas. That is effective. This is done to prevent the bleeding. Suppose the platelet count is between 20,000 to 50,000, INR is between 1 to 3, there's still a chance of bleeding, but the chances are quite less. And if a skilled person is doing it, and the chance of bleeding is quite less. So what do you mean by a skilled person? Okay. See, who is called a skilled person? Okay. So anyone who can, an anesthetist or a critical care person or a physician, whoever it is. So any person who has completed more than 50 cannulations, more than 50, they are termed to be called skilled. In US and all, per year, they have a category to do so many procedures to call themselves as a skilled operator. So as I mentioned, bleeding is one of the important risks that to be taken care. But in case of very sick patients, there's no other go, because you have to weigh between the risk and the benefit and do the cannulation. The second thing, as Dr. Madan was saying, see what are the structures which is present in the neck and also in the chest. Okay, so when we are doing a jugular approach, okay, the common vessel which is near to the jugular vein is the carotids. So there's an increased chance of puncturing the carotids. So when you puncture the carotids, there can be an hematoma which is formed in the neck, which can compress the trachea and cause airway obstruction as well. That is one of the common complications. And the second complication is when we are cannulating, you can even puncture the the pleura of the lung, which can lead to a pneumothorax. Okay. So this is one of the major side effects which happens. The fourth side effect which we usually encounter is when we're doing the central venous access, we insert something called a guide wire. Okay. So when this guide wire is inserted really deep, it goes and irritates the ventricles of the heart. It leads to dangerous arrhythmias. If they are not monitored properly, the patient can have an instant cardiac arrest person. So whenever you're kind of cannulating, make sure the guide wire or the catheter doesn't pass more than 20 centimeters. That's a landmark you have and you do. And other follow-up is when you're using the subclavian, which is in the chest. Okay. So if you puncture the carotids, at least you can even compress the vessel and can stop the bleeding. But when you do a subclavian approach and you hit a vessel or something like that, it can cause a disastrous bleeding. And the femorals are quite safe only, but the problem is it's in the pelvic area and the inguinal region, there are increased chance of infections in the femoral regions. So these are the usual disadvantages which we encounter, and certain precautions needs to be taken to prevent this infection. As I've told, you should do a lot of aseptic precautions. So make sure that it should be done like a proper surgical procedure whenever you're cannulating. So make sure the patient is completely draped and make sure the area is properly cleaned. And the solution that should be used is a chlorhexidine solution and not povidone iodine. Povidone iodine can also be used, but the preferred agent is a chlorhexidine alcohol swab, which is kind of done to clean that area. And third thing is the person who's kind of doing it, he should be wearing a proper surgical mask, caps, and also he should be also properly draped so that he doesn't cause any infection to the patient. So these are the usual follow-ups.
Dr. Srichandran, coming to you next. As a senior consultant interventional cardiologist, I wanted to ask you, for better patient safety, is it practically possible to form a specialized vascular access service team for the assessment, insertion, management, and complications reduction? Is such a team available in any of the specialized care centers today?
Definitely, yes. It is definitely possible to form a specialized team. Basically, the concept of a vascular access specialist team has basically come forward to achieve better outcomes for patients. There are several advantages for having such a team in a big hospital setup. Having a team comprises basically of a critical care physician, internal medicine department, a cardiologist, and also a vascular specialist. So the advantage of having such a big team, the chances of you getting a proper puncture is always great. And that too, the likelihood of a puncture on the first attempt is quite high. And there will be less complications when you achieve it in the first attempt. Not only that, with fewer complications and more precise puncturing of the artery leads to better troubleshooting. And also, such a committee, they're always exposed to the latest guidelines. As Dr. Sivaraj was telling, they'll be abridged to the latest guidelines of puncture. Now, we have moved forward. In the recent past, we used to do a puncture based on the anatomical landmark and various other structures. Now it is precisely through fluoroscopy, and that too via ultrasound guidance. So with a core group of, couple of specialized people, the risks of complications are quite low these days. So basically, now I think in the near future, patients will be asking themselves for a qualified healthcare worker for each and every vascular device insertion and post-op care. There are now several trials and studies done throughout the world, especially in the US, which recommend that when critically ill patients in the ICU, the micropuncture needle and micropuncture and all critical patients have to, they need to get access to a vascular device through a critical care team. So I think that's the way forward. Definitely the team will do a better job in getting access to an artery.
Right. Thank you for that. Dr. Madan Mohan, what kind of education is generally given to paramedical staff and other assisting staff about vascular access?
As Dr. Swamikannu earlier was telling, the site should be very clean. That is, we call it a sterile preparation, because there are enough, when we enter inside the blood vessel, we may carry the infection inside the blood stream, which is more dangerous in the later part. After finishing the procedure, if the patient suffers from infection, that will be a great disaster. So we have to be very careful when we enter the site of puncture. So normally we have to keep everything sterile. The sterile preparation is important for the staffs who are going to be along with us while doing the procedure. So that is the first and foremost safety concern. Next is when you're puncturing, like the patient should be not moving this side or that side, so it should not hit the next blood vessel. So immobilizing the patient is important. So the staff should be very alert and they should fix the patient properly on the cath lab table so that they don't move during the course of the procedure. So we normally, when we are doing it in the hand, we fix the hand and do it. And when we are doing it in the leg, taking the blood vessel in the leg, so we fix the leg and do it. Otherwise, they'll be getting moved from this side and that side, which may go hit the other structures nearby area. So this is the second safety aspect. Then they have to be carefully flushing the sheath often, because when we enter the blood vessel, we keep the sheath inside the blood vessel. Normal tendency, the blood is to get clot. Every 5 minutes, we keep the blood going smoothly. Otherwise, if the blood gets clotted in the sheath, then it will be a problem when we enter the sheath again. So we normally flush the sheath every 5 minutes to keep the line patent. So that will be easy for us to enter, redo the procedure, everything. So this also the staff should be alert in doing that every time flushing the sheath. Sheath is the one which is kept inside the blood vessel of the artery. Then after finishing everything, the compression when we are coming out. So to close the puncture site, how do we do? The compression is the foremost important, because if you don't compress properly, then later on the blood will be oozing from the site of the puncture, and later part after 12 hours after the procedure, the hemoglobin, the blood level will come down. So that time then we have to go redo and make the puncture site suture it. So those are the things we have to be very careful when we compress the area. So that also the staff should be accurately doing the compression bandage. And then when to remove, the timing, everything we have to tell the staffs correctly. So like for example, when we puncture the femoral artery that is in the leg, so we have to give a timing like 6 hours, 8 hours, the patient should not mobilize from the bed. If they mobilize from the bed, then the artery will get oozing, the blood oozing will start. So they have to be immobilized in the bed for 6 to 8 hours. Those points should be told to the patient, and the staff should be told the attender also the timing, how long they should lie on the cot after the procedure. So these are all the education we have to tell the staffs to appropriately tell the patient and take care of the patient precisely.
Dr. Swamikannu, coming to you next. Dr. Shivraj did mention a little bit about peripheral access and central access, but what are the different types of vascular accesses in general that may be required for patients?
The commonest one, as I was telling you earlier, the commonest one is peripheral venous cannulation. The other cannulation that may be required is the central venous cannulation. Now, of late, we have what is called peripherally inserted central cannulation. You can reach the bigger arteries by inserting a smaller catheter peripherally. That is done usually when we need to continue treatment for a longer periods, like chemotherapy. When you want to give it for a longer duration, 4 weeks, 6 weeks, when you want to give a antifungal for mucormycosis, you need a peripherally inserted central venous catheters. So that is another type of catheterization which is used. The other one is the arterial cannulations when patients who are very sick, critically ill, admitted to the intensive care units. When you want to monitor the hemodynamics, the blood pressure, the mean arterial pressure, if you want to monitor all those informations, you need an arterial cannulation. That can be done through the hand. What is called radial artery cannulation can be used for monitoring purposes. These are the 3 common cannulations which is usually done. There are other accesses available, or the AV fistulas for the renal dialysis patients. And also there is, of late you must have been hearing about lot about ECMO. ECMO is used for the recently all these patients who are in respiratory failure. One of the treatment that offered is the ECMO therapy. Extracorporeal membranous oxygen, it is otherwise called. The blood is oxygenated outside the body. So for that, you need venous and arterial cannulation simultaneously. And there are other procedures. I'm sure Madan and Srichandran will be talking about is of late they are replacing the valves of the heart through peripheral artery cannulation. So that's called TAVI, and the mitral valve repair and mitral valvuloplasty. All that is done through the venous and arterial cannulations and simultaneously from the periphery. So these are the different types of cannulation that is being done for a therapeutic and diagnostic purposes.
Right. Thank you for that. Dr. Shivraj, coming to you next. Venous access is one of the most basic and critical for patient care. What are the major types of VADs used in general, and could you enlighten us when to use and avoid each of them?
See, as I was telling you before, what is the purpose of doing it? Okay, whether it's for a midterm or a short term or a long term. Okay, so when you use it for a short term, the major indications, like it's used mostly in the critical care unit. Okay, where we cannulate the jugular or the subclavian or the femoral. Okay, basically it is done to give the fluids, IV fluids. Basically, if the patient is in shock, whether it's cardiogenic or a septic shock, we give certain medicines to improve the BP, which we call it as vasopressors. Okay, and sometimes when the patient is really sick, they need some nutrition as well, where we give something called a TPN, which is called a total parenteral nutrition as well. So the type of vascular, coming to your question of the type of vascular access devices, we have single lumen catheters, we have a double lumen or a multi-lumen catheters, and depending, these lumens will have the diameter of the catheters can be bigger in size. So when the diameter is bigger, the chance of infections are also more. The other type of catheters we use commonly, which is used in the ICU, are called non-tunnel catheters. The catheter is inserted and a part of the catheter is kind of outside. Okay, they are used only for a short-term purpose. For a long-term purpose, we use something called a tunnel catheters. This is basically used for patients on a long-term administration of drugs such as any chemo medications, as Dr. Swamikannu was mentioning. So what is the difference between a tunnel and a non-tunnel catheter? See, when this catheter port, when it comes out, it's kind of stitched under the skin through the subcutaneous plane, and just only a port alone comes out. So there will be a cuff which is outside. So the difference between a tunnel and a non-tunnel catheters are the chances of infection in a tunnel catheter is quite less, because there's a cuff which is there which prevents the entry of the bacteria and other organisms. And we have some other like firm catheters which is used for dialysis as well. So these are the common vascular access devices which are used.
Thank you so much for that. Dr. Srichandran, coming back to you next. What is the risk of thrombosis in various VADs or vascular access devices, and how can you manage this risk?
See, first of all, let's look at the incidence of thrombosis. The incidence of vascular access device thrombosis is around 3 to 50%. Now, how does thrombus actually happen? So it's very simple. It's accumulation of actually fibrin or thrombin inside and around the catheters. So what does it result in? Usually it results in the loss of the catheter use itself. The basic purpose of the catheter insertion is lost. Then subsequently it leads to venous thrombosis, infection, and most probably the only way we can help this is removal of the catheter per se in total. So that would be the main management of thrombosis. The other management protocols are very simple. Anticoagulation with the help of low molecular weight heparin, which is usually given anywhere between 3 months or till the catheter is in situ. And finally, as I told you earlier, catheter removal is the only choice. There's another option called SVC filter, where a filter is placed above the SVC vein, where the thrombus is prevented from migrating proximally. Finally, the last option is thrombolysis, especially when you're about to save a critical limb ischemia. So these are the 4 main options we have. Now, basically, what does all this thrombosis lead to? It results in an increase in the hospital stay. It increases the morbidity of the patient. It leads to further cost. The expenses shoots up. So basically, the thrombosis is a major factor which has to be taken care in the early part itself. Now, this incidence of 3 to 50% is quite high. So unless the early identification is the only way to help in, reducing this risk of thrombosis. And as I told you, management with anticoagulation is the main way. Secondly, if thrombosis is extensive, then the entire catheter has to be removed. So this is how you're going to manage a case of catheter thrombosis.
Okay. Thank you for that, Dr. Srichandran. Dr. Madan Mohan, what are the critical cardiovascular complications involved in vascular access for hemodialysis?
Yeah, see, basically they keep the catheter here in the vein for longer period. So whenever they want a dialysis, they frequently do like a weekly thrice or weekly twice. So they keep the catheter inside the jugular here. So what happens when they put the catheter here? Sometimes it goes and hits, as like Dr. Sivaraj was telling, it may go hit the cardiac part, which is the which we call it as tamponade. So we have faced a lot of people getting this at tamponade. So we have to be, tamponade means that it goes and ruptures the heart. So we have to be very careful when we insert the catheter inside, because it straight away goes to the heart and goes and ruptures the heart. So this is a major complication we encounter during putting the catheter here during dialysis time. The second one will be perforating any vessel. If you put like in the femoral artery in the thigh area, when they are putting the catheter, it may perforate. And it can cause the bleeding inside the abdomen or the thigh area. So this is called as perforation. The third is like when you're doing here, the lung is at the back. So that can puncture the lung and cause air leakage. It is called pneumothorax. So these are the types of complication. One is tamponade, another is perforation, another is pneumothorax. Then commonly seen will be the infection, what Dr. Swamikannu was telling. So that we have to be very careful while putting any catheter. Sterile preparation is must. Then when you keep the catheter for a longer period, see, normally then the vein, in the vein area, the blood can get clotted. That is called thrombosis. So to prevent that, normally we give anticoagulation for a longer period of time. So these are all the 5 complications we encounter during the catheterization for the dialysis.
Dr. Swamikannu, it is for you. I wanted to understand, will experts from different disciplines be part of the vascular access service team? And in that case, what their responsibilities will be?
I think that was already Srichandran has explained. There will be a specialist doing all these interventions, vascular access interventions. That will include internal medicine, then the critical care, then the cardiologist, and maybe the radiologist. Then preventing the complications which are bound to happen, or reduce the complications which are bound to happen. Like they said, the thrombosis, infection, bleeding, and the complications like pneumothorax, the cardiac tamponade, all that being explained by Dr. Madan. So our responsibility is make sure we have a skilled persons, like Sivaraj said. You need to have a skilled people in the team to do the procedure and make sure you get the best outcome. Make sure you don't get infections, and also you teach time to time the staff, make them understand that what is the purpose of the procedure, what is the importance of the procedure, what can go wrong, how to avoid the complications. So by way of doing a continuous medical education for the staff, for the nurses, for your own junior colleagues, and developing the next generation of people to tackle all this will be your responsibility.
Dr. Shivraj, coming to you next. I'm sure like the other doctors have discussed this in some detail, but I just wanted to reiterate this question. What are some of the most serious infections associated with VADs, and how do you manage them?
When it comes to infection, we classify into 2 categories. It's a local and systemic. Local is at the site where the catheter is inserted. So a common thing we usually see is an erythema. Erythema is nothing but a redness or a mild exudate which can come. And for this, basically, antibiotics are not required. I mean, systemic antibiotics are not required. Proper care and a topical antibiotic like ibuprofen can be applied. Okay, but in case the patient develops any systemic signs of infection, we need to stop the patient antibiotic. So this is the local thing. What is systemic? Systemic means when the bacteria enters the bloodstream and causes bacteremia. Okay, so this will include fever. Patient will go in for an early sepsis. They will have altered mental status. Their lactase can be elevated. They can even go for an early septic shock like low BP as well. So when you suspect a systemic infection like or an early septic shock or something like that, how to diagnose it? So you need to draw a blood culture as soon as possible. Blood culture should be drawn from two sides. One is from the catheter side and the other from the peripheral side. At least 10 ml of blood should be sent for culture from two different sides. And depending on the organism which is grown, the antibiotics can be started. So before that, in case if the patient is in shock, we need to start the patient on empirical antibiotics as well. So how do you choose empirical antibiotic cover? So you need to know what is the common organism which causes this infection. The most common organism which causes the infection are the gram-positive organisms. And the most common one are the Staph aureus. So when you have the Staph aureus, we classify it as two categories. One is MSSA and MRSA. When I say MSSA, it is methicillin-sensitive Staph aureus, which is not that sick. And the second category is methicillin-resistant Staph aureus. For methicillin-sensitive, you can usually give a common antibiotic like a cefazolin, where the patient usually responds to it. When you come to a methicillin-resistant Staph aureus infection, either you have to give the patient on higher antibiotics like a vancomycin or a teicoplanin or even daptomycin as well. The second common organism which we encounter in the bloodstream, this is called as a CRBSI, that means catheter-related bloodstream infection, which usually happens if any patient develops fever within 48 hours after the catheter insertion. We classify them as a CRBSI. And you have to exclude other causes of fever as well. The second most common organism is an enterococci. Enterococci also we classify into two categories, whether it's ampicillin sensitive or ampicillin resistant. If it's ampicillin sensitive, ampicillin can be given for the patient. If it's resistant, again, vancomycin or linezolid or daptomycin can be used. The third most common organism are the gram-negative organism, which constitutes about 10% of the infection. Staph constitutes around 60%, enterococcus around 20 to 30%. The gram-negative organism constitutes around 10%. So this also we classify into two categories, whether they are ESBL positive or ESBL negative. Okay, ESBL negative are less serious infection where they usually respond to the common beta-lactam antibiotics. If they are ESBL positive, you have to put them on a higher antibiotics like carbapenems or beta-lactamase inhibitors like that. So this is how we manage the bloodstream infections and the infection associated with it. And the major thing is to prevent this infection, as I told you. So how do you prevent it? Is the proper way or the aseptic precautions you take it. Nowadays, we have something called as antibiotic impregnated catheters also. Okay, so where the incidence of infections are also very less.
So thank you so much for explaining it so clearly. Dr. Srichandran, I would like to go over to you next and ask, why is ultrasound-guided vascular access an important tool for coronary catheterization?
Basically, ultrasound reduces the vascular and bleeding complications as explained by the previous speaker. I would just like to go into the depth of it. There is actually more than 80% reduction in the catheter placement failure with the help of ultrasound guidance. Not only that, there is greater than 50% reduction in mechanical complications such as arterial punctures, local hematomas, pneumothorax, hemothorax. All of them are actually reduced by more than 50% when you puncture with the help of ultrasound. Not only that, you save a lot of money. When you do it blindly with anatomical landmarks, you'll be using more needles, more contrast. Not only that, you'll be the time for the procedure is also huge. So to minimize all of these ill effects, ultrasound guidance is the way forward. Now, future ultrasound guided puncture would be a must for every person. That would be the dictum. See, at the end of the day, already patients are sick in the ICU with other medical illness. We don't want to have them with iatrogenic complications such as hemothorax or pneumothorax or arterial hematomas. So you want to minimize all the complications. You want to make the best outcome for each and every patient. So ultrasound has several advantages. I'd like to go into a little later. But as in the previous past, any femoral access was basically done with the help of anatomical landmarks, basic palpation of the artery, basic fluoroscopy, identification of the femoral head, and then puncturing with a regular needle. But those days are gone now. Nowadays, as Dr. Madan had previously told, we do a fluoroscopy do a proper ultrasound guided puncture with a micro needle. So bleeding complications are quite less. And with the help of fluoroscopy, we pass the wire, and over that we pass the catheter. So the chances of mispuncture is quite less. So once you do ultrasound guided puncture, not only will you target your artery precisely, but you'll also minimize complications. So that's the major advantage of ultrasound guided puncture. Now, there are several more advantages of ultrasound guided puncture. One, once you get your artery in time and you miss your surrounding structures, chances of hematomas, pseudoaneurysms are quite less. So basically, ultrasound guided puncture, especially as the previous speaker had told, with a micropuncture, that is the way forward. That's the future. I think in our
Can I
setup,
add one more thing to that? What Srichandran was telling.
Please go ahead, Dr. Swamikannu.
Exactly, very rightly he was telling. In an emergency, imagine somebody is arrested. You want to do a temporary pacemaker implantation. Time is very crucial factor. So in that time, if you are not able to get the access, it is going to be a tough, and it may result in a bad outcome. So like he said, no, the ultrasound is going to be the future, and guiding through ultrasound, it's going to get the puncture done in time, and it may save lives. So I just want to add that particular area where you need to insert instantly and get the heart going. So ultrasound is going to play a huge role in future. Only the thing, in the ultrasound machine should be available. Nowadays, the small handheld, the ultrasound machines are coming up. So in future, it may be the way forward to do the vascular access puncture.
Right, very interesting insight there from both of you, Dr. Srichandran and Dr. Swamikannu there. Dr. Madan Mohan, going over to you next. How does a patient's cardiac status determine the choice of dialysis and the type of vascular access?
There are two types of dialysis we normally take it forward. One is CRRT and another is the CAPD. See, what is CRRT is continuous renal replacement therapy. So why we choose CRRT is when in the failed heart, the suddenly removing the fluid is very dangerous. So we have to remove the fluid very slowly in the heart failed patient, so that the heart cannot get damaged like hemodynamically. The vitals like pulse and BP will get maintained throughout the procedure. We have to do slowly, like instead of doing dialysis in 3 hours, this will be done at the rate of 24 hours. So normally, generally for a heart failure patient, the CRRT is advised. Then second is like a CAPD, continuous ambulatory peritoneal dialysis. So again, there also it is the fluids are removed out from the body in a very slow manner. So these are all things for the heart failure patients. So normally we recommend CRRT, where slowly the fluid is removed.
Dr. Swamikannu, coming over to you next. My question is, what are some of the major hemodynamic changes that lead to cardiac consequences during hemodialysis?
We have been doing it for the hemodialysis and peritoneal dialysis. The hemodialysis is, you are removing the certain amount of blood continuously and purifying it and getting it back to the blood circulations. So the fluctuations of blood pressure during dialysis is known to occur very commonly. The blood pressure depends on 2 important factors. One is the cardiac output. The other one is the peripheral vascular resistance. During dialysis, the cardiac output tends to come down so that the blood pressure falls drastically during the dialysis. This is one of the complications or the adverse reactions that come during dialysis. So the reduction in the cardiac output, fall in the blood pressure, it will adversely affect the perfusion of other organs in the body. So the cardiac events that you are going to end up in a low cardiac output status, because of which most of the organs will not be getting their share of blood supply. So one of the commonest complications that occurs during the dialysis is hemodynamic disturbances, which is the fall in blood pressure. What we call is hypotension during. The other thing that can occur is infection. through the dialysis process, you may, if it is not done in an aseptic manner, it may end up in infection. The other hemodynamic disturbances that can occur is the bleeding. Bleeding also can occur if it is not done properly, the puncture is not done properly, it can lead to. But by and large, the commonest complication is the hypotension because of the reduction in the cardiac output.
Right. Thank you for that, Dr. Swamikannu. Dr. Shivraj, how can a health professional identify ongoing and delayed complications with vascular access devices?
So as I was talking before also and explaining, so what the complications we usually encounter, we classify into two categories. One is immediate complication, other one is a delayed complication. Okay. When you say an immediate complication, the first one is a bleeding, which can usually result in hematoma, which can be diagnosed actually by an examination itself or by an ultrasound, you'll be able to diagnose that. The second complication, as you mentioned, is an arrhythmia, which usually happens, which you can see because all the patients are connected to the monitors, multi-para monitors. So you'll be able to detect the arrhythmias, or the simple ECG, you'll be able to detect an arrhythmia as well. The third complication, which I told you, is a pneumothorax, which I was mentioning, or hemothorax as well. A proper ultrasound chest or a chest X-ray. In case any doubts, you can even do a CT of the chest to identify this complication. And the fourth important complication is an air embolism, which can usually develop. Okay, this air embolism which develops during the removal of the catheter as well. So the proper precaution as well, the patient should be kept in the pendulum position. And the second thing, what you have to do is, like while removing the catheter, make sure the patient is an expiration phase, that's the Valsalva manual, so that the intrathoracic pressure is more than the atmospheric pressure and there's no chance of any air embolism as well. So these are the usual immediate complications we usually encounter. The delayed complications, we usually in long-term venous catheters when we have all those things. The first thing which I was telling you during my last, when we spoke, is about the infection. So where we do a blood culture to identify it. The second is the vascular devices or the catheters getting blocked, which we call it as stenosis. And as Dr. Srichandran was mentioning about the vascular thrombosis also. So how do we detect these things? We detect by usually doing a Doppler ultrasound where of the upper extremities or the vessels where you'll be able to identify the thrombus as well. The other complications are, as Dr. Madan was telling about cardiac tamponade as well, which can be easily identified by doing an echocardiogram. And sometimes you can, in long-standing devices, it can even cause some myocardial ruptures as well, nerve injuries. So these are the common delayed complications.
Right. Thank you for that, Dr. Shivraj. Dr. Srichandran, do VADs related complications increase economic burden on patients and healthcare system? And how can it be prevented?
Yeah, this question has actually been answered by the previous speaker. Definitely, it increases the economic burden of the patients. And how to prevent such complications are quite simple. Do a proper puncture by a specialist team member. So that would be the first step. Second is early identification of complications. All the complications which was addressed by the previous speaker, Dr. Shivraj, has to be identified in an early manner. And the early diagnosis, saves a lot of complications. So making a quick diagnosis and rectifying it in an early way will definitely help in, preventing further issues associated with the complications. Now, there are several complications which has to be, discussed in detail, such as a simple infection, if not, identified in an early way, such as patients who present with fever, having hypotension, tachycardia, basic mechanisms such as hand hygiene, proper site preparation. All of this will lead to, less chance of infection. When you come to a condition known as air embolism, which was just spoken by Dr. Shivraj, how do you identify air embolism? First, look for signs of sudden onset of dyspnea, which is new in onset. Look for any vague chest pain. Look for any new onset cough. Again, look for signs of tachycardia, that is high heart rate. Look for low blood pressure. All of this will give a suspicion of air embolism. So how do you prevent this? Make sure your syringes which contain fluid and prevent injection of air into the system. Use a closed system which has connectors, such as a lock mechanism where even if air is injected, it's prevented by the lock. Subsequently, how do you manage air embolism? Give oxygen, change the patient to the left side with the head actually lower than the heart level, and prevent, obviously the most important is to prevent further air leak. So this is as far as air embolism is concerned. Coming to catheter occlusion. Now the catheter can be occluded by several mechanisms. The most common one is thrombosis. as we had already spoken earlier, thrombosis is a very notorious complication, and the only way to prevent is, again, early identification. If you suspect thrombosis of the catheter, start anticoagulation as early as possible and give for at least 3 months. Suppose you have to have an indwelling catheter for longer duration, please continue anticoagulation as long as the catheter is inside the lumen. Now, other common side effects as far as catheter is concerned is a catheter malposition. Suppose you feel your catheter is actually moved out of its position. In how to identify this? Just check for backflow. If there is no backflow, obviously your catheter is out of position. Then the only way in helping the patient is removal of the catheter and reintroducing another new catheter. So these are how the ways, where you can help in quick identification of all these complications so that the economic burden of the patient is not skyrocketing. Thank you.
Right. Thank you for that, Dr. Srichandran. Dr. Madan Mohan, what are the potential complications that can occur during the procedural placement of central venous catheter insertion?
See, as we discussed earlier, this is the area where we put the central venous catheter. So as I mentioned earlier, like one is like going and hitting the heart where the tamponade, then perforation. So all those things and air embolism, like everything is when we put the central venous catheter, we have to precisely monitor and look for it. And another complication apart from this central venous, I like to tell about the new emerging technology in this new era, where the valve replacement, like without opening the chest, we implant the aortic and mitral valve through the artery and vein from the femoral area, that is in the thigh. So which is more crucial nowadays because the catheter size is very big for this TAVI. The TAVI is nothing but the aortic valve implantation through the artery. So earlier the catheter what we use for the angios are very smaller ones. It's a 5 French catheter. But the catheter what we use for the TAVI is very high, like it is 20 French catheter. So it is very huge compared to the catheter what we use for the coronary, that is for the angio. So we have to be very careful when we introduce those catheter inside the vessel. So for this, all the points what we have been talking about, one is fluoroscopy, ultrasound guided. So these are all very essential to avoid all the complications like puncturing neighboring vessel or blood clotting, like hematoma near the site area and aneurysm or fistula formation. So these are all very crucial things we have to see while puncturing the artery because it's a big high French 20 French catheter. So there's a new emerging technology, this TAVI. When we do, we have to be very precise while doing it. So for that, we take the fluoro and mark the area, that femoral head, that is the bone landmark we take. And with ultrasound guide, we puncture the vessel. One is anterior, posterior puncture. We have to puncture in the anterior, that is above. And then we see the bifurcation of 2 blood vessels joining. Above that, we have to puncture. So that these are all the markers for puncturing the vessel. If you puncture exactly above the bifurcation, that is 2 blood vessels joining and anterior puncture, so no complication will arise. So which is very essential for when we do the TAVI. So these are all the points which we have to think before doing, so to avoid all the complications as we said earlier, like a perforation or hematoma formation, all those things.
Thank you, Dr. Madan Mohan. Dr. Swamikannu, would you have anything to add to the same question about the complications arising due to the...
One of the things which we missed somewhere along the line is the losing the devices during procedure.
Yeah, correct. Yeah, that's an important
sometimes
thing.
We lose the stent, sometimes we lose the guide wires. This has happened with me 1 or 2 times. So I just wanted to add that you have to be careful in holding the guide wires and your stents in place. So nothing more to add. It was a good discussion.
Yeah, it's called a closure device. See, we all talked about the puncture, how to prevent the complications. Anticoagulation, there is a system called closure device. So we have to use the per-close. It's called per-glide, where we use that per-glide insert like a suturing. So normally those days there's a compression. So blindly compressed after the puncture area while coming out. But now for the closing, we have the per-close device with the suture material and other things. The patient can even walk within 2 hours, 3 hours because it gets the glued. The glue is kept in that area. It gets sealed nicely. So we use this per-glide for closing the puncture site area in the vessel. So this is the latest thing emerging, and we started using those things now.
It is better we have a protocol for each procedures, and so that we prevent the complications and prevent the patients paying more, especially the economic burden. Not only the economic burden, the hospitals say the man days lost is also will be more if they tend to stay because of the infection, because of the complications of the vascular access procedures. So the key is training and training and training. You get trained yourself.
Dr. Shivraj, I wanted to ask you, in addition to the contemporary techniques, what are the modern techniques available to optimize various vascular access procedures, which improves the patient safety through lesser manual interactions, thereby minimizing the risk?
See, as everyone had discussed, first going to the history of the vascular access, actually. The first vascular access device or the catheter insertion was done in 1957 by Mr. Seldinger. That's why it's called Seldinger's technique. So over the period of time, it has kind of completely evolved. 20 years back and all, people used to do that procedure very blindly, in the sense like people view the anatomical side, they kind of visualize, they palpate, and they feel the carotids, and then they push it and kind of do the venous access. Now, going against the contemporary way, as it was discussed, now we use something called real-time ultrasound access. Okay, so when you use ultrasound, there are two things. One is static, and other one is dynamic. Okay, when I say static, means you just put an ultrasound probe and you just mark it, and afterwards you kind of do the procedure. When I say it's dynamic, you still visualize the guide wire going in, the needle going in. So the operator who's kind of doing it should hold it on one side and insert the needle. Sometimes some people prefer someone else to hold the probe, the ultrasound probe. Okay, so it's better the same person does it, where it will be much more easier. That is number one. The number two, the type of probe which we use for ultrasound is also very, very important, because sometimes we might be doing in some very tight locations where we need a thinner probe, like a hockey stick kind of probe. And the normal probes are usually flat. And if it's an obese person, you need a much more like a curved probe, something like that. So the type of probes you use is also very, very important. So ultrasound guided access, like a real-time ultrasound, is really, really very important, as we had discussed earlier. And so doing a procedure through a real-time ultrasound, it saves time, it saves the burden as well, and it's safe for it's really safe for the patient. And in real time nowadays, we have something called intravascular ultrasound, where we'll be able to see the vessels inside, putting a probe inside the vessel. We'll be able to see the atherosclerosis, the plaques, and stuff like that. So we have something called an angioscope, an intravascular ultrasound, etc. Probably the cardiologist should be able to add a thing about intravascular ultrasound for the coronary procedures.
Thank you so much for that, Doctor. I think in continuation with this topic, Dr. Srichandran, I would like to ask you, what are the contemporary techniques used to achieve optimal arterial access in cardiac catheterization?
Yeah, it was just spoken by the earlier speaker.
Yes.
Nowadays, actually before coming to the latest procedures, in the foregone era, it was basically done on inspection, palpation, and then doing a blind puncture. But those days are gone now. As we had just discussed now, first we'll usually do fluoroscopy, identify the femoral head. We're talking about the femoral artery per se first. So identify the femoral head, make sure you puncture with a micropuncture needle just above the bifurcation of the two femorals, and that too with the help of an ultrasound guidance. So I'll repeat again, fluoroscopy, identify the femoral head, ultrasound guidance, use a micropuncture needle, and then visualize the needle specifically going into the artery, pass a guide wire, a floppy guide wire, and through that we pass a sheath, probably a 5 French or a 6 French sheath. Then start the angiogram as per any normal procedure. So this is the most recent contemporary way of accessing a femoral artery for femoral angiograms. As Dr. Madan was saying, with newer novel therapeutic procedures like TAVI or any IABP or ECMO, those kind of procedure require a large bore access needle. So with help of ultrasound, we would minimize the incidence of contralateral artery puncture or surrounding bleeding into the abdomen. All of this can be prevented by ultrasound guided puncture. So this would be the most advanced technique of making punctures in the femoral. As far as the wrist is concerned, there is the radial artery. Again, we can puncture the radial artery with the help of ultrasound guidance, because we want to avoid any radial nerve injury or contralateral ulnar injury. All that can be prevented by help of ultrasound guided puncture.
Right. Thank you so much, Dr. Srichandran, for that. Dr. Madan Mohan, I wanted to know, for better patient safety, what are the critical improvements that need to be implemented in order to minimize the errors and complications during vascular access?
Yeah, it's like a clubbing the whole agenda today. I think as all doctors commented, so one is like ultrasound guider, another is a fluoroscopy. So these are all the gadgets we use with special needles like a micropuncture to prevent all these complications. And one more thing I like to add here, the small babies like ASD, VSD, like a hole in the heart. So normally we forget called the air entering the hole from one chamber to the another chamber, which will go to the brain and cause brain issues. So to prevent that, what we generally recommend is there is a Venflon. See, we normally put Venflon for starting the drip. So there is a special Venflon called filter Venflon. So there is a filter inside the Venflon. So the air won't go inside the vein. So then it won't cross the one chamber to the another chamber, from venous to the drip we put here. Then straight away the air goes to the heart through the venous side and goes to the brain. So it crosses from one chamber to another chamber through the hole. So to prevent that, we use this filter Venflon. So we have to keep in our mind whenever we give all this fitness for this ASD, VSD surgeries, for other surgeries, these kind of patients, we should use filter Venflon.
Right. I would like to pose one more final question to Dr. Swamikannu and Shivraj and wrap up the session. So Dr. Swamikannu, coming to you next, how can a patient be educated on vascular access safety, and what sort of informed choices should they make to avoid compromising their safety?
Very, very, very important to get the consent of the patient before you do anything. The entire procedure is to be explained to them in a language that they understand, and also get the consent that they are willing, telling them all the complications that can come around the vascular access procedures, especially when you are doing a cardiac catheterization. It may be a simple peripheral venous catheterization. So you have to tell the patient, there are patients who, by look of it, they'll faint. So you have to tell them that when you puncture, there will be blood. So I've seen incidences where the moment they see the blood, they faint. So make them understand what is a procedure that you are doing, what are the complications that can come around, and get the confidence of the patient and make them understand. That will be the key to do any procedure and for the good outcome.
Right. Thank you so much for that, Dr. Swamikannu. Dr. Shivraj, my final question to you would be, what do you think is going to be the future of vascular access technology? We did discuss a few of those aspects, but any emerging studies or research aspects that you are particularly excited about?
See, I like to talk about AV fistulas here, okay, because we haven't spoken about it, AV fistulas. What is an AV fistula? Why is it created? Actually, it is used usually for a dialysis patient. Okay, so this dialysis patient or on a catheter, these venous catheters, and probably you can't keep it for some time. So you have to create a fistula which is done by a vascular surgeon. Okay, so what happens? So sometimes these catheters, so what is a fistula? It's just a graft which connects the artery and the vein. Okay, sometimes those gets blocked as well. So common the graft which is used is the prosthetic graft, which is pentatetrafluoroethylene graft. So what happens when all the vessels are thrombosed or blocked? Okay, you need to create a very like another graft. So another emerging thing which is happening is something called a hero graft, which is something but the hemodialysis reliable outflow graft basically. So what happens with this? We use this prosthetic graft which connects the brachial artery and as well, and it is then connected to another lumen. That lumen, that's a single outflow lumen which is connected to the major vessels and it goes to the right atrium. So this is one of the modern techniques which is being followed in people like where all the vessels are thrombosed and the AV fistulas are unable to be created in the upper extremities. Then we have other grafts as well, such as the allograft, the xenograft, and also tissue engineered graft, which has been emerging in US, but it's not yet approved right now, which kind of mimics the human body cells. And these grafts have got a lesser chance of infection. So when you say the allograft, these are the nothing but cryopreserved vessels, like the femoral vessels, which are cryopreserved. And the xenograft are nothing but the bovine, the coronary vessels, and the mesentery vessels, which are usually prepared, which cause less chance of infection. These are some emerging things which are happening in the vascular access right now.
Right. Thank you so much for that, Dr. Shivraj. With that, we come to the end of this very, very interesting and insightful session. So thank you so much for joining us today, Dr. Madan Mohan, Dr. Swamikannu, Dr. Shivraj, and Dr. Srichandran. It was a very informative session. I'm sure there are like a lot of takeaways. Thank you for joining us, joining the Times of India as well as Biological E on this webinar on optimizing vascular access and patient safety. We hope to have many such informative sessions with you in the future. Thank you so much.
Yeah.